the pleasure to introduce Dr. Haykel.
Thank you.
Haykel Kamoun from Tunisia, and he's one of the. We don't have talk with him. We don't have presentation. Yeah. So we're gonna just this. It's gonna be a talk between friends. So he's one of the developers of AJL PRO.
Yes.
He has a lot of experience in intracorneal rings. And the first question that I have for you, doctor, is how or why do you think in an asymmetric corneal ring?
Okay. As you know, refraction is not vision, but shape is vision.
Okay.
And we know today to improve vision in keratoconus patient, you have to reshape the cornea in order to homogenize the cornea. And as Professor Alfonso described in 2016, we have 5 phenotypes of keratoconus, and we have symmetric one and asymmetric keratoconus. And as you know, we have a very good result with standard ring in symmetric keratoconus, but not in asymmetric shape, which are duck and snowman. So the idea started from there. So it's better to use asymmetric for asymmetric shape, and the best deal today is to adapt to each keratoconus shape the best ring profile.
Exactly.
So for that we developed asymmetric rings for
very clear for the public.
Uh,
So another question for duck phenotypes. Do you think it's the best indication or the asymmetric corneal ring? Because we see
both.
Such a good results with ducks.
Yes, with ducks and also with the snowman. Even with snowman, we have to put two asymmetric rings.
And with duck, you
only
just
one.
Exactly,
Yes.
exactly.
Thank you very much.
Thank you so much.
And I would like to thank IGL for supporting me for producing such ring, because as you know, producing asymmetric ring is very difficult technically. And I would like to thank them for supporting me and for believing in my project.
No. Thank you so much, and congratulations for this amazing work. Thank you, doctor. Thank you.
Bye.
So, Dr. Kamoun from Tunisia talking about the asymmetric rings, and now I have the pleasure to invite here one of the most important speakers in keratoconus and intracorneal rings, a good friend from Argentina also, Dr. Carlos Gordillo. Carlos, welcome back.
Thank you very much, Andres. It's a pleasure to be here. Thank you to Ophthalmic University, to the company, and to all the colleagues that are here today. And well, the idea of this conference is to give some ideas and tips regarding the progressive rings.
Thank you so much for being here again, and let's go.
Okay, let's move on. So, do you have my presentation already? It's not here yet. E3. Yeah. Thank you. Okay, great. Well, thank you very much again for the invitation. It's a pleasure to be here. Thank you to Reyes, Felipe, and all the colleagues that are here today. So the idea of this presentation is to try to explain you how to perform the surgical plan and how to select the cases for the progressive rings. So the principal objective of this class is to identify the cases that require this indication, to understand the functions of the intracorneal rings, the techniques and the approach of the technique, and also to understand the steps of the surgical plan. So for that, I have to be very grateful with Dr. Alfonso that was here before, because he was the one of the doctors who teach me about how to select the patient, the type of intracorneal rings that we have, the variety of the measurements of the different rings, what parameters we should consider, and also it's very important to understand the expectations, the patient's expectations and also our expectations. So as I was telling you before, Dr. Alfonso teach me with Dr. Fernandez Vega about the classification. So it's very important to understand the shapes, the parameters that will teach us in which kind of keratoconus we can use these kind of intracorneal rings, because you have different parameters, different phenotypes, and these intracorneal rings are not for all of them. So the idea of this slide is to show you the different types of intracorneal rings that we already have in the market, and the new one is the progressive one. So far it's been 2 years since I started using these rings, and I'm really happy with the results and also the patients. So this is the intracorneal ring I was talking about, and I will show you some cases and how do I choose the patient and what you should do at the surgery room. So I always show this to my patients. It's like a worldwide map. It's always useful to understand how stepping is the cornea and which are the summits of this surgery. So once you have the patient selection, you need to make an interpretation of the topography. Then this is the most important part of the surgery, to understand the axis. You have the chromatic, the refractive, and the topographic axis. I will show you later how to choose all of them. Then once you have done that identification of the axis, you can choose the intracorneal ring, make the surgical plan, and then the technique is always the same, but with these intracorneal rings you will have some different specifications. So in this congress in Vienna, we presented our 4 results in comparison of 3 different platforms of femtosecond to perform the tunnels. So I will share with you these results because with all of them it's really good. We studied 3 different groups in all patients with dark phenotype using 3 different platforms. For each platform I analyzed 10 cases with more than 6 months of follow-up. So you can see here the difference between one platform and the other one. I have the opportunity to use intralace femtosecond, Zimmer femtosecond, and lenses from Alcon House. So there you can see the difference between one another. For all the patients I use the same tunnel. So you have the inner tunnel in 5.8 and the outer tunnel in 7.8. And then the deepness of the tunnel is going to be around 70 and 80% of deepness. So to understand it better, I will show you this case. In this case, you can see the topography, and also in the pentacam, you can look for the intracorneal rings display. There you will be able to identify the chromatic axis, the topographic axis, and also the refractive axis that you need to know when you make the refraction of the patient. As you can see there, you have more than 10 and 15 degrees between one and the other. That's good enough to choose this kind of ring. You can see there in the picture, you'll be able to see the pupil. It's perfectly surrounded by the ring, so the position is it's perfect. So here you can see a video with the different platforms I was using for this study. All of them are safe enough and good enough to show the results. So the difference between one and another will be the surface. 2 of them has like a plane surface and 1 of them has a curved surface. So the docking is also different between one and the other. And also you have to see always the center of the cornea. You need to take in account the center of the cornea, because if you have a platform like Intralace or Zimmer, you'll have a plane applanation. So the center is going to move. You'll be able to see now how it moves in the Intralace in the center of the screen. When you put the ring, the cone, there you can see how you need to move a little bit the cone and move the center of the cornea. After that, you'll be able to implant the intracorneal ring, and with all of them it's the same. Usually you don't need to use any instruments to introduce the segment. And as a good tip, you will need to move a little bit forward from the indecision because it can move a little bit. If I have a progressive keratoconus, I also perform cross-linking, so that's why you'll see that I'm taking out the epithelium. So these are the results of this first presentation. The results were really good in all the cases, and we had like a really huge improvement in visual acuity, considering corrected and uncorrected visual acuity. Also, you have a great decrease in the keratometry values, and the cylinder changed from a mean 5.8 to a mean 1.75, so it's really big. So apart from that, you'll see the aberrometry values, and there you can see the total value of the high order aberration and how big is the reduction between pre-operative evaluation and post-operative evaluation. It's the comma values goes almost to the normal value. That's really important to see because if you identify the value of the cornea before you perform the surgery, you'll be able to compare. And not only the patient will be happy because of the visual acuity, also because of the visual quality. So to be more clear, I'll share with you one case. So this is a 31-year-old patient with a high astigmatism that was increasing. So as you can see, the visual acuity was 20/50 and 20/40, and you have the patient had a potential of 20/25. So after performing the diagnosis of progressive keratoconus and corneal ectasia, you'll have to identify again the parameters I was talking before. The pentacam is really easy because it shows you in red all the values that are not normal. So once you identify that, you can also perform the progression display to follow up the patient and to see if it's having a progression or not. If you have a progressive case, you can combine the techniques with cross-linking. Otherwise, you can only perform the intracorneal ring. So for this one that was progressive in both eyes, I did a calculation. Again, topographic axis first, then chromatic axis, and finally the refraction axis. As you can see again, you have more than 30 degrees of difference. That's a good reason to choose this kind of ring. So this is the ring I choose. Also for the left eye, you can see there the difference between one axis and the other one. This is really important to understand because if you understand the axis, you'll be able to choose the proper ring. And this is after the surgeries. You can see the center of the cornea and the periphery of the intracorneal ring. Also, you can see the tomography and the difference between the intracorneal ring sizes, the progressive sizes. You can see it there. So in the 6-month post-operative evaluation, you are able to see the results with a great decrease in the astigmatism and a great improvement in the visual acuity. So from 20/50 to 20/25, and you will see how it changed and reduced the astigmatism and improves the visual quality and the visual acuity. Also the left eye. And here you have the comparative evaluation in the topography. So you can see the pre-operative evaluation, the post-operative evaluation, and the differential map for the right eye and also for the left eye. So I have another case to share. This was a case also with a bilateral keratoconus, but in this case only the left eye was the one that wasn't with a good visual acuity. So I do it again. I put the topographic axis, the refractive axis, and the chromatic axis. There again you can see more than 50 degrees of difference between one and the other, and the dog phenotype. This is when I go to the surgery room, I perform the surgical plan, and there you can see the pre-operative and the post-operative evaluation. Actually, this was the first case I performed 2 years ago, and well, right now, after 2 years, I'm really like sure and convinced that this is the best option for this kind of phenotype. You can see there the postoperative evaluation. Actually, this was inside the surgery room. You can see the pupil is still small because I used pilocarpine before performing the surgery. So the last case, it's also bilateral keratoconus, but this kind of different, it was not like that clear dark. So I decided to perform this intracorneal ring in the left eye, and you can see there the results, the postoperative results. In this case was huge, the amount of astigmatism that was able to reduce with the ring. You can see there the visual acuity and also the surgical plan. So sometimes you have different parameters or different phenotypes. This was like a duck, but the direction of the duck is horizontal, so it's different. I had to think about this case like a right eye, but it was a left. So the incision was different. I performed it in that way, and you can see there the difference between one surgical plan and after the surgery. So to finish, I will give you my conclusion for this kind of phenotype, duck phenotype. This is nowadays, for me, the gold standard for the treatment of keratoconus, because it not only reduces the corneal aberration, it gives the patient a better and more visual quality and visual acuity. Okay, thank you very much.
Congratulations, Carlos. Thank you so much for your talk. It wasn't easy with the sun on your face, but
okay,
you did it.
It was okay.
Great.
I did it.
It's the sunset.
Yeah,
exactly. We cannot do anything. So, Carlos, we were talking with Dr. Haykel. Do you think that now we are thinking, or we have a mindset that with the intracorneal ring, the asymmetric, we are thinking like refractive surgeons, looking for a refractive result as you just showed us? Because a few years ago, we just really wanted to reshape the cornea, right? Then contact lens, whatever. But now we are having great results, refractive results with these patients.
Okay, yeah, it's a good concept, but we always need to try to regularize the cornea. If you are treating the cornea, you need to be sure that you're doing the best to regularize the cornea. It doesn't matter if you, after the surgery, need to perform 1 year after an ICL, like a phakic IOL, because you're looking for the visual quality and the refraction after the surgery. No matter you have a low astigmatism, you have a big quality of vision.
Exactly.
So the patient is really happy. Actually, they tolerate contact lens. They have very good visual quality and quantity with glasses. So after 1 year, if you have a big myopia, maybe you can offer the patient another refractive technique.
Exactly.
But it's like when I think about the technique, I don't think to take them out of the refraction. Actually, I tell the patients, for sure you will need sunglasses or contact lens until you finish your postoperative evaluation after 1 year. If you tell that the patient, you never will have a problem because you are being clear.
Exactly. And the same question that to the other speaker, you said that the duck phenotype is one of the best results with this.
It's
asymmetric.
amazing.
It's amazing, right? We are.
Yeah, actually, it's, for me, I don't have another option for this kind of phenotype. And if you are a good, if you perform a good screening in keratoconus, you'll find this kind of phenotype at the beginning.
Yeah, so, absolutely. Well, Carlos, thank you so much for your time. I know you're super busy, so we really appreciate it.
It was really nice to be here. Thank you.
Thank you so much.
Bye-bye.
Well, we're gonna move on. We are having a great symposium, and now with the sun on my face, it's here. We're gonna present the next speaker from France. Welcome, Dr. Sofiène Kallel from Hôpital des Quinze. I don't know if I said
Quinze-Vingts. It's a French
I don't
name.
speak French. Okay,
Yeah.
I'm sorry, but for friends, let me do this.
Okay, I will check my
you can,
presentation.
Yeah, minimize. Okay, okay. So, Sofiène, we're going to talk about double progressive intracorneal ring segments.
Yeah.
Until the presentation is ready, can you tell me since when are you using this kind of intracorneal rings?
Okay. It starts with the first version of progressive intracorneal rings. It was with another company, and it was two kinds of intracorneal ring progression. The first version was only on the depth, on the thickness of the cornea of the ring. It works very well, and I tried with that like more than almost 200 eyes. Then, unfortunately, in France, the commercial stops importing this kind of rings. So, at that moment, we had another company with another kind of rings, which the progression is different because it was with the base. It worked, but not enough.
Okay.
And finally, and fortunately, like 2 or 3 years ago, AJL PRO provided revolutionary rings with double progression. I mean, in thickness and in base, and it's logical in our practice because the cornea of Keratoconus is really not accurate. It cannot be simple progression in it, and it was a really revolutionary solution. Actually, I had so many patients. We had data of them, and we are very happy with it.
Okay. How many patients, Sofiène, do you have with this new technique, this new AJL Pro?
Actually, between 180 and to more than almost 2,000 eyes.
Wow!
Yes.
Wow! That's a lot.
Not 1,000. Excuse me. 100.
100. Well,
to
it's the same.
200 patients.
So you are more convinced that these kind of rings are a little bit better than just the progressive, the one single
as I will
progressive.
show you, there is two family of Keratoconus, and there is a family of Keratoconus with irregular cornea, which are really, which need really the progressive rings. So that's what I'm presenting today.
Okay, perfect. Sounds great. Sofiène, I think we are ready. Yeah?
Just a second.
Okay.
Okay. Hi everybody. Thank you for the invitation. Today I have the honor to speak about the evolution or the revolution of the new intracorneal ring segment with the double progressive in the treatment of keratoconus. So as you know, intracorneal ring segment are these devices with the shape is or almost the shape and the thickness of rigid contact lenses, and this is how it looks like into the eye and with the an OCT image. So previously we had symmetric intracorneal ring segment, which was the first version of the corneal rings, and the procedure was very easy. For in my practice, I start with the markage of the pupil place in front of an interior slit lamp. Then we use the femtosecond, and as you see, we can move the axis to be sure that the axis is on the right horizontal axis 0, 180, and in front of, centered on the cornea. Then the laser goes, and with that way we are sure to have the axis corresponding to the shape, the real axis. Then the procedure is really easy. I have to make a small dissection, then we put the ring into the cornea, and the procedure is really easy to perform, no difficulties. And after that, in the first days or the first weeks of the cornea, we can imagine the ESCRS function. Look into these two red lines. It looks like something going into the anterior chamber, and if we join these two lines, we can imagine like a myopic correction. And even in the front part of the cornea, I mean in the epithelial thickness, look at this place and look at the thickness of the epithelium in this place too. And if we join these two lines, we can imagine that it represents negative correction. So it depends. If it's circular, it can be a myopic correction, and if it's for astigmatism, it can be just oval one. This is a case of bow tie keratoconus with -7. We put two intracorneal ring segment symmetrical, and the result 4 months after looks like something much better with regression. This is a type of croissant with -6 of astigmatism. This needs only one intracorneal ring symmetrical, and 4 months after we have a very good result. And you see with the differential map that the shape of the regression corresponds to the rings. This is another croissant, but is bigger, so maybe in this case with -11 of astigmatism, almost 12 dioptry of astigmatism, we put 2 rings, and the result was not bad. We lose the half of the astigmatism. This is the nipple shape of keratoconus, and it needs a 320 shape rings, and the result is very good. So you have to understand that for symmetric keratoconus like bow tie, we should put 2 rings, similar things. In the croissant shape, 1 or 2 rings, it depends on the power of the astigmatism, and with nipple we can use only 1. For asymmetric keratoconus, which are the asymmetric bow tie or snowman, the asymmetric oval or the pellucid-like, like the lobster claw, in this case we cannot put symmetrical and normal rings, and in these cases we need to put progressive intracorneal ring segments. So the revolution is with this new AJL PRO product, which is double progressive. I mean, the progression of the thickness and the base is guaranteed in these rings. So you remember this function of the postoperative results. In this case, as you see, we put a progressive ring, and in the OCT we can see here the difference between the beginning of the ring and the end of the ring. And look at the posterior part. In this case, you see that the effect on the epithelium is better on the thicker part of the ring, and the effect is, of course, much important. And even if we consider the posterior part of the ring, we see that the effect is more important. And this is not the same as the beginning of the ring and the end. And as you see, the power cannot be the same, because even the thickness and the base are not the same. So the effect will not be the same, and of course there will be a progression. So the procedure is quite the same, so centered on the cornea with the laser. then a small dissection, which is very easy, but it's important to center the treatment on the center of the pupil when the patient is not laying down. Then we put the ring, and it's very easy to put and to respect the axis. The axis is really important to show. And at the end, the procedure doesn't lay there more than a few minutes. So this is a case of a duck patient. So in this case, we put a corneal ring. 1 month on post-op, you see that the difference is very important. And if you compare, this is a very, very, very good result with minus 14.22, as you see in the bottom part of the screen. This is the result of 1 month. So this means that there is an overcorrection. But if you see 6 months after, in this case, we see that the progression is the result is a little bit much good, much better than the first one. So if we look at these two images, 6 months after, the post-operative differential map looks like less important. So this suggests that there is like a small regression. And if you look to these two maps and we make the difference, you see that there is a progression of, in this map, plus 6.36, which is not the keratoconus regression, but it's the overcorrection of the epithelial mapping, which changed. This is a case of a snowman. So we put 2 corneal rings. This is the result a few months after. And look at the differential map. The difference is very, very interesting. This is inverted snowman, which needs 2 rings. The result is very good, and look at the differential map, which is exactly the effect we have to reach. This is a duck example. In this case, we put only 1 ring, a progressive ring at this place, and you see the differential map, which is very interesting, and the shape of the regression looks like the effect, the duck effect. This is a lobster case. In this case, the result was good with only 1 ring. And here we see that the differential map looks like more than 11.5 difference. We had 33 eyes in our study, but only duck type. We can say that uncorrected visual acuity and corrected visual acuity in 6 months we had win 2 lines for between preoperative and postoperative. 78% of our patients had at least 2 lines of better visual acuity, with less sphere, with less cylinder, and a better equivalent, spherical equivalent. We had a reduction of 39% of the coma and statistically significant results. So in conclusion, for symmetrical keratoconus, we need symmetric intracorneal ring segment, as in the bow tie, the crescent, and the nipple. For asymmetric keratoconus, we need, in this case, asymmetric and progressive intracorneal ring segment, like in snowman, duck, and lobster lobe. Thank you so much.
Thank you so much, Sofiène. Excellent talk, excellent, amazing results. You know, 40% of reduction of the coma. That's great.
Yeah.
Right? For the patient, for the quality of vision.
Yeah.
I want to ask you, do you combine sometimes this procedure with cross-linking, for example?
Yeah. In some cases, it's needed to combine intracorneal ring segment and the other procedure. It can be cross-linking or something else after that.
And you do cross-linking before, after, at the same time?
No,
It
the
depends.
logical plan is to perform first the rings for two reasons.
Yeah.
Because the cornea is still soft,
Softer,
so
yeah.
we can do whatever we want with it, and then we can fix it and make it not moving much more with cross-linking.
I agree 100% with that protocol. I do the same. But again, I'm impressed with the results. AJL PRO, I think they are a great tool for this kind of keratoconus. Thank you so much, Sofiène, for your time and for your patience with the issue that we had with technical issues. Thank you so much.
No problem. Thank you so much.
Okay, we're going to move forward, and I have the pleasure to present Sofia Vitucci. This is easier for me to say your name. It's not French. So Sofia is from AJL, and she will be talking about some news that the company has for all of us. So Sofia, thank you so much for your time.
Thank you for
And the time is all yours.
Thank you. I will be quite fast. Let me find the presentation. Here we are. So, hi to everyone. I would like to introduce to who doesn't know yet our Keratoconus service, who is a professional support that AJL give to doctors and whoever needs in case he needs help for ring calculations or difficult cases for keratoconus. So anytime you can send all the data to ask us an opinion or information. We can personalize the calculation based on corneal topography, considering the curvature, the interior and posterior elevation maps, and of course the pachymetry, as we also take in account the aberration, so the coma with its magnitude and axis, the refraction of the patient, and the best corrected visual acuity. Of course, case history of the patient is always important. Additional information that we would like to consider, if are available, are the visual potential with rigid corneal lenses, contact lenses, and the surgical technique that will be used for ring implantation. So otherwise, online there is the AJL nomogram that can help for ring calculation to create the plan. So it's, as I said before, our calculations are based on corneal thickness, so the pachymetry, the aberration. We need information about asphericity, astigmatism, and coma, and also the keratometry, so the case value. It's easy to create an account, so if you already, if you don't have already an account, you can go to our page and just register, filling up the data, and be able already to straight away to log in. Of course, we have to introduce the patient ID, and important, the preference of the brand of the ring that you are considering, and accepting, of course, the licensing. So how we use our nomogram? So briefly, I can show you how introduce the data, in how present our nomogram I show in the website. So first space is for the K1 and K2, so the keratometric value, the cornea, the coma axis and magnitude, the pachymetry value, and the Q value. So after that, the nomogram will suggest a plan that is what we consider is the best, and that can be downloaded from a PDF with all the data necessary for the order and the implantation. Very important is that you can find different options suggested by our nomogram. So very important is to know that in case this case is suitable for and can benefit from AJL PRO, so a progressive asymmetric ring, you can find it as a first option. Otherwise, you have option for 6 mm or 5 mm, depends on the case. So you can select the file, the PDF that you want to download. So as doctors better explained before me, I want to remind about AJL PRO, which is a symmetric intrastromal corneal rings with a double variation, with a double variable progression in base width and thickness. The arc length available is 160 degree and 2210. This is because is what the asymmetric phenotypes require. In clockwise and counterclockwise configuration depends on the shape of the ring that you need, and the optic zone is available in 5 and in 6 mm. So last but not the least, we want to inform that AJL will launch the AJL ring for regulatory reason. We have to introduce to this new brand that will have same triangular shape, same parameter and references as Ferrara, available in 5 and 6 optic zone, with all the thickness and the length as before. And it will be like a transitional period to switch and to pass completely to this new brand. So that's it. I try to be very
but let me tell you something. No, it was great, but let me tell you something. I think this is the most important talk, because you are teaching us how to make the plan. This is very important for all the people that are watching the video, because you are a great support for the surgeons for the very first cases, when they have some doubts, when you don't know what kind of AJL ring you want to.
It's exactly what I always try to transmit to new doctors that start with this technique to the ring implantation. Is to give a support, to confirm, to learn how to select the best plan, the best option.
Absolutely.
And support to confirm that their calculation is good. And also very important, even for doctor with a lot of experience, I know that there are many difficult and complicated cases, so maybe they are happy to ask questions, because we can see many different difficult cases. So
Absolutely.
maybe we try to give this support.
Yeah, and always it's good to have the support of the company. Again, in those first cases, we have a lot of young people in Ophthalmic University watching this. They want to give the first steps in keratoconus surgery. And this is great, because they are not alone, and always the first steps are the more difficult. No,
but it's exactly
when you are starting the curve.
It's exactly what I feel every time I talk to new doctor, because new to the technique, young or less young.
Don't freak out, because we have great speakers, outstanding speakers with a lot of years of experience. But if they are in the first steps, AJL has the support for all of you guys.
Yes. So first, mainly at the beginning, they can concentrate on the technique, on learning, and we support for the calculation, which is really complicated, and it takes a while to be confident with the calculation, to understand the aberration, the effect of the aberration in vision. So after that, when they are fine with the technique, I always take care to teach them how to play with rings, with plants. And then I always say it's a kind of art.
I saw you in the wet lab teaching the doctor. She's very good. So if you are in the next, I don't know, meetings or when you see a booth of AJL, Sofia is always here
we try to
with the wet lab.
And wet lab.
Take advantage.